Great. So welcome to the third presentation on GMDC Pediatrics tutorials or pediatric preparation towards our licensure exams. So let's start. So we have a 10-year-old boy who presents to the clinic with a limp and a swollen right knee. So the person is what? Kind of limping, and it's what? A swollen right knee. So what comes to your mind is this person is having what? A joint problem. Joint, because it's a right knee. It's a new joint. All right. So you have a 10-year-old child who is limping and having what? A swollen right knee. So definitely you know that this person having what? Arthritis. Arthritis. Now pain in the knee joint, we call it arthralgia. Arthralgia. But inflammation of the knee joint, we can lead to pain. We call it what? Arthritis. So already you know that this person has what? Arthritis. It's in your mind. It's a child. So you start thinking about every other thing. Start thinking about it. Anything that can lead to joint pains and stuff, start thinking about it as a differential. As simple as that. All right, so let's begin. List two differential diagnoses. List two differential diagnoses. And one of the differential will be what? Septic arthritis. Of course, you have what? Inflammation of the knee joint, which means arthritis. So this arthritis or this infection could be septic. When we say septic, it's a generalized or a systemic what? Inflammation. And that can lead to what? Arthritis. So you write septic arthritis. And children, they develop sepsis a lot. Small time they're having infection. Small time they're having temperature. So septic arthritis of the right knee joint. Septic arthritis of the right knee joint. That is one of the differentials. 2, the person can start bleeding inside the joint spaces, and that can lead to what? To swollen knee or arthritis. So we call it hemoarthrosis of the right knee joint from hemophilia. Hemoarthrosis of the right knee joint from hemophilia. You know hemophilia. Somebody can start bleeding into the joint space, and that can lead to what? Inflammation, and that inflammation can lead to what? Pains in that knee joint or in those joints. So hemoarthrosis of the right knee joint from hemophilia. If you say these things, your examiner will begin to love you. Third, this could be a juvenile or idiopathic arthritis. So we call it juvenile idiopathic arthritis, meaning it has no known cause. All we know is that it's a child and we don't know the cause and there's arthritis. We call it what? Juvenile idiopathic arthritis. Juvenile idiopathic arthritis. There can also be what we call osteosarcoma. Osteosarcoma can also be there. Osteosarcoma of the distal femur. Osteosarcoma. This means that there is some sort of what? A neoplastic lesion. Neoplastic lesion in the bone. So that can also lead to what? Arthritis. So we call it osteosarcoma. Osteosarcoma of the distal femur. So again, we have septic arthritis of the right knee joint, hemoarthrosis of the right knee joint from hemophilia or secondary to hemophilia. We can have juvenile idiopathic arthritis. Then we can have osteosarcoma of the distal femur or femur. The distal femur or femur. So these are your differential diagnosis. What it means is that every other thing we're going to give should be in reference to our differentials. Otherwise, whatever we are writing is wrong. Otherwise, whatever you are writing, forget about it. It's wrong. Just forget it. Forget it. Forget it. All right. Now, outline 4 important points in the history indicating their relevance. Indicating their relevance. So again, you have your differentials in your head. You have already written them down. That's septic arthritis, hemoarthrosis, idiopathic arthritis, osteosarcoma. So if for nothing at all, you can't write anything, find something to write about hemophilia. find a question to ask the person or a point from hemophilia that can help you to be able to confirm your diagnosis. As simple as that. So one, since we are talking about septic arthritis, you might want to ask them if they have any symptom of what? Infection. So any inflammatory symptom is allowed, or it's a point you have to look at for. Is the place warm to touch? That is the only area. Is the place warm to touch? Is there erythema, or is there redness at the place? Is the person having infection, generalized infection, like is the temperature high? All of these things are things you want to ask under septic arthritis. And already I've given you 3 points under septic arthritis. So warmth or differential warmth, you want to ask for erythema, what is what? Redness, because you know that anytime there is inflammatory process, there's redness at the place. You want to find out if there is temperature, because obviously there'll be a temperature, isn't it? There'll be high temperature. So you will want to ask of those things. Very good. Then you can move to what? The hemophilia. So you want to ask, is there any history of any bleeding disorder? It's a history you have to find out. When the patient bleeds, does it take a longer time for the bleeding to cease? It's something that you have to find out from the person. Has the person ever been diagnosed of low platelets or thrombocytopenia or something like that? You might want to find out of this, because this can also be what? Be hemoarthrosis. You would want to find out. And is there, and you know that hemophilia too is also what? One or the other is also what? A hereditary sort of problem, isn't it? So you want to find out if there are other children from the parent having similar episodes. You would want to what? Find out from them. You would want to find out from them. So at least you can give like 6. Now, if they say something is idiopathic, you can't get any point from that. Means we don't know the cause, isn't it? So at least with these 2 differential, like the septic arthritis and the hemoarthrosis, you should be able to get a lot of points from it. And the reason why I don't write the answers for you guys is because I want you guys to listen and also go on and search for them and add more points. Because the more you research and add more points, the better you remember during the exams. All right. So we have mentioned a lot of them. Great. For each of your differential diagnoses, you see, so they are making reference to your point number A. So that means that if your point number A is wrong, it's not correct, things here could be not correct. But then again, if your diagnosis is in reference to it, whatever point you are giving is in reference to your differentials, even though you might mark wrong, but they could give you some point for the fact that everything is sequential, or you are doing it based on your differential diagnosis. So it's very, very important. Very, very important. Now, for each of your differential diagnoses, indicate one diagnostic investigation and the expected result. Indicate one diagnostic investigation and the expected result. So, of course, septic arthritis. Who can tell me what diagnostic investigation you would do for septic arthritis or for sepsis? Don't forget, it's coming from the word sepsis. So who can tell me? Let's learn. Who can tell me? Anyone? You have infection. What diagnosis are you going to do? What investigation are you going to do to clarify? Come again?
Culture and sensitivity.
Culture and sensitivity. Thank you. So you want to do culture and sensitivity. So what will be your expected result? Of course, it could be positive, isn't it? When we say positive, it means that there could be either gram-negative or gram-negative, but bacteria is what present. So culture and sensitivity could be what? Positive. It could be what? Positive. So you want to check it. Don't also forget that under your differentials, we can also have rheumatic fever. Because rheumatology can also lead to what? Rheumatism can also lead to what? Joint pains. So you can even add rheumatism to your differential diagnosis. I just remembered. You can add what? Rheumatism or rheumatic fever to it. You can add it to it. Very important. Very good. So now let's come back to our differential diagnosis and the diagnostic investigation. And again, for hemophilia, what will you do? You would want to do factor 8, factor 9 assay. Factor 8, factor 9. And factor 8 will mean what? Hemophilia A. Factor 9 will mean hemophilia what? B. Very important. So you want to do what? Your clotting factors. Clotting factors. So factor 8, factor 9. Factor 8, factor 9. So factor 8 will tell you that this is it. Factor 9 will tell you that this is it. As simple as ABCD. As simple as ABCD. So again, everything should connect to your differential diagnosis. And if you're thinking of rheumatism or rheumatic fever, you want to do what? A rheumatoid factor test. Very, very what? Important. You would want to what? Do all those tests to ascertain your diagnosis. As simple as ABCD. All right. For any of your differential diagnosis, outline 2 key principles in the immediate management of this child. In the immediate management of this child. Don't forget that this is not an emergency case. So don't go and say that, oh, do your ABCD. No. You are deviating from the question. You are totally deviating from the question. So you can just take one. So if you are taking septic arthritis as your final diagnosis, they are saying that what 2 key principles are you going to do to manage this child? So 1, you would want to what? Arrest the bacteria, isn't it? So you want to give what? Antibiotics. So antibiotic medication, you have to give it. Then for the fact that the person is having what? A swollen right knee, to tell that the person could also be having what? Joint pains. Definitely there will be joint pains. That's why the person is limping. So then there's pains there. The person is limping. So you want to give what? Analgesics. You want to give what? Analgesics. You would want to give analgesic. And you might want to add what? Infusions to it. Infusion to it. And again, let's come back to our differential diagnosis. I just remember, you can also talk about what? Sickle cell disease, because we just spoke about vaso-occlusive crisis. And under vaso-occlusive crisis, patient can present with what? Joint pains. So that can also be what? Your differential diagnosis. And if that is also part of your differential diagnosis, what it means is that you can give more points under the history taking. Because you want to know if the person is sickle cell, the mother, the father, you want to know all of these things. And you want to know if the person has recently gone through some stress and all of those stuff. So you see how when you begin to solve the questions, more ideas keep coming. You can think and go on and go on and go on and go on and go on. A lot of information are there. A lot of information are there. Don't be restricted. There are a lot of things. So for us, you can justify your answer. My dear brother, my dear sister, write it and go your way. And that is how it is for the Viva sections. Very good. So again, if you're talking about sickle cell disease, again, you can know the management already. Infusions, analgesics, yeah. That's all. Basically, that's all. Then if you're thinking of the hemoarthrosis, that's hemophilia. So you might want to give definitely treatment for hemophilia is you want to give what? How do you call it? Fresh frozen plasma or cradle precipitate. Cradle precipitate. You want to give these things. Or you want to give blood transfusion because the person could be anemic as well. So all of these things are there. All of these things are there. All of these things are there. So write them and go your way. Write them and go your way. As simple as ABCD. All right. A 5-year-old boy has 2-week history of nasal congestion. 2-week history of nasal congestion. And 9-time cough, which has worsened over the past 3 days. The 9th cough has worsened over the past 3 days. His past medical history is significant for recurrent cough. Recurrent cough. Recurrent cough. Okay. His younger brother was diagnosed with eczema during infancy. During infancy. So they're not bringing this history for bringing sake. So again, There's nasal congestion. There is cough that gets worsened. That was worsened in the past 3 days. Past medical history is significant for recurrent cough. That means something that has been there. It keeps going, it keeps coming, it keeps going, it keeps coming. Then his younger brother was diagnosed with eczema, with eczema, with eczema, with eczema, with eczema. So at least you know these things at the back of your mind. So now let's begin with a question. So definitely you are thinking of a problem with the bronchus, isn't it? Or the fact that respiration and stuff are being impaired, or they are being obstructed, one or the other. So you are trying to cough to bring out those things. You remember we talked about asthma some few lectures ago. Yeah, we talked about asthma. We talk about cough. We talk about all of these things. So please, these things, they are just walk over. All right. So based on the likely diagnosis, based on the most likely diagnosis, what 3 additional points will you elicit from the history? Briefly indicate their relevance. So a lot of things. So first of all, what is your diagnosis? Because whatever you're going to give must be connected to your most likely diagnosis. And the most likely diagnosis here could be bronchial asthma. Bronchial asthma. Bronchial asthma. As simple as that. Bronchial asthma. So if it's bronchial asthma, you should know the points to give. You should know the questions to ask. You should know why you are asking those questions. Why you want to know those things. You should be able to know. Good. So what 3 additional points will you elicit from the history? So 1, you want to know the family history of asthma. Family history of asthma. You want to know it. So find out, oh, is there any member in your family that has asthma? Even the mother, the father, do they have asthma? You will want to what? Find out from them. And then are there any known triggers or allergens? Any known triggers or allergens? Because these things can exacerbate the condition, or it can trigger the condition. It can trigger it, and a lot of problems could start happening. So you would want to what? Find out from them. And is the person even on medication? Are they following their protocol? Are they taking their inhalers? All of these things are questions you will have to ask them. And briefly indicate their relevance. Of course, family history, you know why you're asking them. Because you know that asthma is also what? Could be hereditary, isn't it? So you want to ask. Because if your mother is asthmatic, it's likely that you can also develop what? Asthma. As simple as that. And you ask of any allergen. So has the person been exposed? Because if you get exposed, you are likely that you will start having the symptom. So if you don't like spray, if you use the spray in the room, the person will start coughing because it's irritating them. It's irritating them. Dust is irritating them. Pollen, it will be irritating them. It all depends on the person's type of what? Allergen. So that is why you want to what? Find out. So that is its relevance. That is its relevance. So you should know then, especially on any medication. Because if you're not on medication and any little thing, you will start what? Experiencing the symptoms. So you want to what? Find out. And they're giving you a 2-week history of nasal congestion. That tells you that the person is also having what? Upper respiratory what? Infection. So infection can also be a reason for why the person is having all of these things. Already now you have asthma. Your bronchus are not correct. And now you're having nasal congestion again. Now wahala. So you want to find out if the person is taking medications for the nasal congestion. Is he on any any antibiotics? Is he on any all of those things? Mention them and go your way. All right. So I've mentioned a lot. So please write them and then be able to find your way around them. All right. Now outline 5 important physical examination findings that might be present. Again, this goes back to the same thing that we discussed about asthma. We talk about asthma. We talk about a condition that will make this person becomes, acute condition or acute exacerbation, that become very severe, we talk about them. We talk about inability to complete sentence. We talk about the chest. We talk about the breathing. We talk about all of them. Okay. So 1, inability to complete sentences. Inability to complete sentences or a full sentence.
Dyspnea.
Dyspnea is there. Good. Very good. Continue. Tachypnea. You'll be having difficulty,
Yeah.
so you're trying to breathe.
Tachycardia, tachypnea, dyspnea.
Thank you. So all of these things are all part, and in the use of accessory muscles for respiration. The use of accessory muscles of respiration. The person become what? Lethargic and irritable. These are all physical findings they're going to see. They are all physical findings you are going to see. There are a whole lot on them. They are on a whole lot. So mention them, keep mentioning them, and keep going your way. As simple as ABCD. All right? Mention them, and then you are free to go. Mention them and keep going. All right. And sometimes, because they're having difficulty in breathing, they can have some slight cyanosis too. So you can see some bluey discoloration. Some bluey discoloration. And the reason they are lethargic because they are trying to breathe, so they are tired. And this is a 5-year-old boy. So very, 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 very key. Very, very key. So you have to mention all of those things. All right. Now outline 2 key principles in the immediate management of this patient. Now, whether they've told you that this is an emergency or not, these things are normally what? Emergency cases, because they won't come to your hospital if it's not an emergency. Isn't it? They wouldn't come. So first of all, you want to make sure that the airway is what? Is patent. You want to make sure that the airway is patent before you start doing your stuff. So just do that. But then basically, you want to give bronchodilators. You want to give bronchodilators. You want to give what? Oxygen, because like I said, ABC. So you want to give what? Oxygen and all kind of things. Okay, somebody has written them for us. Very good. So you can just look at them. Rodney has written them in the chat section. I think the physical examinations. Very good. So again, your 2 key principles. You want to do what? Bronchodilation. And that's when you want to use what? The salbutamol. So nebulize with salbutamol. Nebulize with salbutamol. And you want to give what? Oxygen. Oxygen. So intranasal oxygen. Then you want to give what? An anti-inflammatory agent. So that we give what? Glucocorticoids. Because the person is what? Is reacting. So you want to lower the immune system. So the reaction what? Will be reduced. At least just mention 2 and you are good to go. That's all. Just mention 2 and you are good to go. Mention 2 and you are good to go.
Repeat the last point again, please.
So the last point is anti-inflammatory agent like glucocorticoids. Glucocorticoids. Because the person is, don't forget, asthma is more like hypersensitivity reaction, isn't it? So you want to decrease their immune system so that it will not what? Start reacting. And by decreasing, you can give what? Glucocorticoids, IV corticoids, or hydrocort. Glucocorticoid or hydrocort. Then oxygen, then salbutamol. All of these things you will want to give to the patient. All right. List 2 important acute complication of this condition. Acute complication of this condition. So now look at it. This is how to answer this kind of question or this kind of thing. First of all, you know that it's a respiratory problem, isn't it? The person cannot breathe. So what do you think is a possible complication? What can you think about as a complication? Who can tell me one?
Cardiac arrest.
Cardiac arrest. Thank you. What else?
Respiratory failure.
Respiratory failure. Good. What else? What else? Because you understand that it is respiratory problem. So anything under respiration, mention it. there will be hypoxia because you don't have oxygen. So there will be what? Hypoxia. And again, if oxygen is not perfusing in the brain, what can it lead to? It can lead to what? Brain injury. Brain injury. So you have what? CNS injuries. CNS injuries. And again, and because how do you call it? The lungs is not pumping very well and stuff like that, it can lead to what we call pulmonary edema. Pulmonary edema. We can lead to collapsing of the lungs called pneumothorax. So you see, everything is correlating. So you can talk about the respiratory failure, you can talk about cardiac arrest, you can talk about pulmonary edema, which will lead to pneumothorax, you can talk about CNS injuries. That is how to. So don't say that, oh, this is what I know. No, think about the question, think about the condition, and start answering. As simple as ABCD. All right. A neonate is referred on the day of delivery with a midline swelling at the lower back. Midline swelling at the lower back. Midline swelling at the lower back. So when we talk about, a day. So that means one day, day one on the earth, there was what? A midline swelling at the lower back. So just put your hand at your lumbar area. Very good. So that's what they're talking about. Midline swelling. So there's swelling at the lower back. Swelling at the lower back. Midline. Very good. So you start asking yourself, what could be your differential or what diseases are connected to this thing? That's what it means. That is what it means. All right. So list 3 other structural abnormalities that may be associated with this condition. So you ask yourself, so now, let's say this is your, let's say this is Alphonse. So Alphonse, and this is Alphonse back. Alphonse. This is Alphonse. And this is back.
Yes, boss.
Good. This is your back. Alphonse back. Okay. Sorry. So normally your back is like this. Our back is like this. It's like an S shape. Our back is like an S shape. Good. But here's the case. Over here, this part, we are having what? Swelling at this area. So this place is swollen. Okay. So that's what the lumbar area. That is the lumbar area. So you ask yourself, first of all, the thing that comes to my mind is, what structure can I find under the lumbar area that can possibly lead to swelling at the place? So what structure? Do you know that your kidney is at the lumbar area? Okay. So if you don't know, your kidneys are at the lumbar what? Area. So what it means is that there could be what? A malformation in the genitourinary tract. There can be what? A malformation in the genitourinary tract. So for that reason, there could be problem with fluid coming out of the kidney, and that can lead to what? Accumulation over there, and that can present as a swelling in the lumbar area or in the lower back. So genitourinary tract abnormalities. Genitourinary tract abnormalities. And again, you ask yourself, what other thing can happen for the fact that there's fluid accumulation over there? So in a nutshell, you can think of edema formation, isn't it? Because swelling is more or less like edema. And we've talked about the edema. That edema can happen, causes can be from the heart, it can be from the GIT, it can be from the kidney, it can be from the liver. But this is a neonate, this is a child. So what abnormality are you going to think about as a possible cause of edema? Yes, heart abnormalities. Heart problems. Because first you have talked about kidney problems. Now you can talk about heart problems. So you can talk about heart malformations. People who are born with defects can lead to fluid accumulation in the lower back area. Then you can also think of what? Hydrocephalus. Hydrocephalus. That means fluid accumulation in the head. When you have too much fluid in the head, which sometimes people are born with it, so it's a congenital what? Malformation. We call it what? Hydrocephalus. Hydrocephalus. List 3 key points that should be obtained from the history. 3 key points that should be obtained from the history. You read that when we're talking about this, we're talking about what? Something that you are born with it. So you want to find out if there are siblings that are also affected with similar condition. So affected siblings. And sometimes too, if the mother doesn't take a lot of folic acid during pregnancy, folic acid helps in neural tube formation. When I say neural tube, that's the CNS formation. So if the folic acid is deficient, it can also what? Lead to such a thing. So you want to look at what? The maternal intake of folic acid. And you also want to look at maternal diabetes mellitus. So people who are diabetic, especially before pregnancy, they can have these sort of things happening to their child, especially the hydrocephalus. So you give the and sometimes the baby head is very, 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 very big. Microsomia, right? Very, 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 very big. So these are some of the points you will want to find out from or you want to know from the history to help you with your management. List 4 aspects of the physical examination of this baby. 4 aspects of the physical examination of this baby. So first of all, you want to check first of all, we mentioned something about what? The heart. So you want to examine the heart to check if there's any problem with the heart. So check the heart if there's any problem with it. So you know what to do. Auscultation and stuff like that. So these are the 4 aspects of the physical examination. So you want to do what? Examine the heart, auscultation, to check if there's any abnormal heart sounds, some murmurs being present and things like that. And because that can inform you on the investigation to do, isn't it? So that means if you have a problem with the heart, you might want to do what? Your ECG, you might want to do what? Your echocardiogram. Very good. So 4 aspects of our physical examination. 1, you want to examine the heart. Then you want to measure the head circumference. You want to know the size of the head. Because don't forget, you said hydrocephalus, isn't it? Microsomia, all of these things, big head stuff. So you want to measure the circumference if it is correlating to the normal size of a baby head or a neonate head. Then you also want to know the mass. So you want to examine the mass. You want to see the anatomical locations of whatever that's happening with the baby, the size of the baby, and all of those kind of stuff. You want to know the mass. Measure the weight. Get to find out if weight is corresponding to the norm. Normally, a neonate, fresh, normally I think 2.5 to about 3.5, isn't it? Kg, 2.5 to about 3.5 kg. That would be their weight. So if it is too heavy, 4 kg, then it's a cause for alarm, isn't it? It's a cause for alarm. So you want to know all of these things. All right. Now, apart from a pediatrician, some of the key physical examination, you want to also check the motor and then the sensory innervations and the presence of any malformation. You want to check the abdomen as well. The blood, like I said, people with let's say urogenital abnormalities, you can be able to palpate the kidneys and stuff like that. So you want to check if there's any abnormalities, if it is palpable or it's not palpable. So you want to check the abdomen, the bladder, the kidneys. You want to check for the sensories. If you touch the person, if you pinch the person, can he, will the child cry? That's like motor and sensory innovations. You want to check, so you are sure that there's no CNS problems. Good. So now let's move to the fourth point. Now, apart from a pediatrician, list 3 other specialists that will be involved in the management of this baby. So, of course, you want to look, because we're talking about people with malformation of the bones, like the varus, isn't it? The varus that we talk about, the varus. So these people, orthopedic people. So you need what? Orthopedics. You need neurosurgeon or neurosurgery. You need a cardiologist or a cardiothoracic surgeon. You need a nephrology or a urology because of the kidney. So all of these I'm going to mention should correlate with your structural abnormalities. With that, you are good to go. Easily, you are good to go. As simple as ABCD. So these are so again, neurosurgeon, orthopedics, cardiology or cardiothoracic surgeons, nephrology or urology. You can talk about clinical psychologists. You have to psych them. Clinical psychology. So these are the possible department or specialists that might be involved in the management of this baby. All right. A 6-year-old boy presents with fever, respiratory distress, physical finding of a new heart murmur. You are informed that he had a sore throat. When I see questions like that, I just smile because we've done it before. So before I continue with the explanation, having a sore throat, what do you think could be the possible pathogen for having a sore throat? And they're saying 3 weeks ago. They haven't given me another clue. Who can tell me what could possibly be the causative agent for sore throat? Who can tell me? We have discussed it in Croc 2 before.
Is there a streptococcus?
Come again? Yes. So you're thinking of a case of tonsillitis, isn't it?
Yeah.
And we mentioned that tonsillitis can have a problem, or some of the complications of tonsillitis can be in the heart, can be in the kidney. We talked about these things. So always put them at the back of your mind, because you always apply. And it doesn't change. This is medicine. It doesn't change. Of course, we can update, but it's like that everywhere. Okay, so definitely you are thinking of a tonsillitis as a possible cause of whatever new heart murmur this person is experiencing. Okay, and if you have a tonsillitis causing a heart pathology, there's a name that we call it. We call it what? A rheumatic heart fever. That's what we call it. All right. So let's go to the questions. So what is the most likely diagnosis? So this was acute rheumatic heart fever. Acute rheumatic heart fever. This one, no need to stress your mind on it. And one of the complications that this heart fever can lead to is what? Mitral what? Stenosis. That's the reason why we're having what? A heart murmur. Mitral stenosis. You can have infective endocarditis. You can even have myocarditis. These are some of the complications you need to be looking out for, so that anytime they mention sore throat, you know what they're talking about. All right. Now, briefly explain the cause of this condition. Again, we have told you, this is because of the what? The tonsillitis. So what it means is that, and like I said, you are thinking of what? Streptococcal infection, isn't it? So we can say that strains of group A beta hemolytic streptococci become very susceptible to the host, or when these group A beta hemolytic strep gets into the host, it begins to cause an abnormal immune inflammatory response. Again, strains of the group A streptococcus gets into the host of the person and starts causing an abnormal immune inflammatory response, and this begins to lead to the infection or begin to cause this condition. This is what pathophysiology. So they're talking about the pathogenesis, the pathophysiology. How does it happen? It happens because the infection from the tonsillitis or the agent for the tonsillitis has now migrated, or it has now affected the host to the point that it is now causing an abnormal immune inflammatory response, which is causing the above symptom or the above diagnosis. As simple as ABCD. So if you don't treat tonsillitis very well, you can lead to acute heart fever, acute rheumatic fever. All right. So now list two aspects of the primary prevention of this condition. So basically, we are talking about the sore throat. We're talking about the acute rheumatic fever. It's about what? Basically about the tonsillitis. So what will be your primary prevention? So one, try as much as possible to prompt and complete treatment of sore throat. So you want to prevent the rheumatic fever, you have to make sure that the tonsillitis is well treated. Two, you have to reduce overcrowding because this strep is everywhere. So reduce overcrowding, then do what we call public education and awareness. All right. So these are the basic things that you need to do to prevent it. That's all. Hygiene, very important. Very, very important, because if you don't brush your teeth very well and stuff like that, it can lead to sore throat. Okay, so Alphonse, be brushing your teeth, okay? All right. What is the most important aspect of the outpatient follow-up of this patient? Follow-up on this. So this is what outpatient. The patient is going home. So normally, what we will give for this kind of condition is what we call benzathine. So we give penicillin called benzathine penicillin. You can give IM, and this IM, we don't give it. It's like you give a start dose. They will go home and come back the next 3 weeks or 4 weeks for another dose. That's how we give the benzathine penicillin. You give, you go home, you come back. We give, you go home and come back. Or you can also give oral penicillin to prevent reoccurrence. Okay, but if you don't give the IM, they will go and come back. So basically, that's the most important aspect of the outpatient follow-up on this patient. So IM benzathine penicillin. As simple as ABCD. All right. Now you heard this question. They didn't mention about what investigation you would do and stuff. So this is now up to you to go and start reading on acute rheumatic fever and get to know which test you will do, which confirmatory test you will do. Maybe you might want to do culture. Maybe you might want to do streptolysin O. You see, you might want to do all of these things to confirm your diagnosis or to confirm that this is indeed an acute rheumatic fever from the tonsillitis. Okay. So you should always know what to do. So we have a 5-day-old boy presented to the emergency room with a bleeding circumcision. Oh, so those of you who go and cut the baby's this thing, no? The foreskin, no? It's called circumcision. So now the patient have what? A bleeding circumcision. So you ask yourself, why would there be a bleeding circumcision? Sorry, why would the person be bleeding? Yes, you will bleed normally, but to the point that it's now an emergency case, meaning that clotting is not happening, isn't it? So there is a bleeding disorder, and what comes to your mind is that there could be a possible, what, hemophilia disorder, possible what, hemophilia, possible how do you call it? Maybe thrombocytopenia. Who knows? So these could be your differentials in your head. Be thinking about them. And you know that sometimes you need vitamins to also help in the coagulation. So anything that relates to coagulation, think about it. Anything pertaining to coagulation, think about it. It can also be that the person who did it is a quack doctor. It's a quack doctor. So it's always possible, isn't it? It's always possible. However, this is an emergency case. So let's continue with the questions and let's know what to do for the patient. So outline 4 key points you would obtain from the history with justification. History with justification. So again, you ask it. So now that means that before you can give these 4 points, you need to start having differentials in your head. That can help you very, very much. And what are your differentials in your head? You are thinking of what? A possible hemophilia. You are thinking of what? An improper technique by the, or you're thinking of a quack doctor doing the thing. You are thinking of a possible DIC, that's disseminated intravascular coagulopathy. You are thinking of a thrombocytopenia. You are thinking of a drug-induced, a whole lot of things. Can you think of a bone problem? So all of these are things that are in your head. So out of these things, just mention 4 points. That was just going to help you with it. That's all. So 1, you can mention what? Family history of any bleeding disorder. Family history. So this family history is going to point towards what? Hemophilia, isn't it? Exactly. So you want to know what? A family history. Family history. And again, apart from the fact the person is bleeding on the circumcision area, is the person bleeding into deep tissues? Is the person having any joint pains? You remember we said anytime you have hemoarthrosis, it can lead to what? Joint pains, isn't it? So you want to find out if this child is also having what? Hemoarthrosis. Hemoarthrosis, meaning bleeding into the joint spaces. That can also cause what? Joint pains. So when you try to tilt the person's knee, is the person crying? Because a child, so you can't be able to tell that, oh, I'm having joint pains. It can't tell you. So all of this, you want to what? Elicit it to know for sure. And again, you want to look at the skin. If the person is bleeding into the skin. So normally we call it petechiae or whatever they call it. Isn't it? Petechiae. So you want to check all of those things. Some bruises on the skin, and then bruises on the skin and stuff like that. It could be a reason. Again, it could also be heading towards what? Hemophilia and what? All these platelet deficiencies. Okay. Then again, you want to find out any drug therapy that the patient is on or the child is on. Was he given any drug? Because this could also be what? A drug induced, isn't it? It could be a drug induced. You need to check for any drug thing. Very good. You need to check for any drug thing. So these are the points that you can easily elicit from the history. Now I can go on and say check for leukemia, check for all of this, but then you will not have labs, because this you need labs to be able to justify. For example, liver disease, you need a lab to be able to know. Bone marrow, you need a lab to be able to know. A plastic anemia, you need a lab to be able to know. But of course, anemia can be present. For example, is the person pale? So you can ask, is the person what? Pale? The person's pale. Is it paper white? So all of these things are points you will want to find out from the history. Okay, so now they've told you, list 2 differential diagnoses. And again, we've mentioned them. So you can have what? The hemophilia. You can have the a bleeding vessel from an improper technique. You can have a liver disease. You can have a bone marrow failure. You can have a plastic anemia. You can have leukemia. You can have DIC. You can have drug-induced. Some people are even on herbal preparations. You have to know all of these things. Some people say, oh, he was having temperature, so I gave aspirin. Aspirin is a drug-induced. Aspirin is drug-induced. Drug-induced. Good. Someone is also asking, is also adding Van Willebrand disease. Yes. Because all of these are all what? Bleeding disorders. So you can just add them. Even vitamin K deficiencies. Vitamin K deficiencies can also lead to it. All right. So all of these are different. So you can just go on and go on and go on. List 3 important investigations you will do and indicate their relevance. Again, so everything should be based on your differentials. So if you're doing clotting profile, why are you doing clotting profile? Because you're thinking of what? Hemophilia, you're thinking of bleeding disorders, isn't it? So you do what? Your clotting profile. You want to do a specific factor assays. Specific factor assay. Like which one? Like factor 9, like factor 8. You want to do them. You want to find out the bleeding time. Bleeding time. You want to do what? Liver function test to check for any liver disease. Then you want to do what? Grouping and cross-matching. Very important. Because people who are bleeding like this, you want to do what? Transfuse. So do your grouping and cross-matching for possible transfusion. So the grouping and cross-matching is not going to help you to diagnose. Or it's not for a diagnostic purpose. Of course, it can tell that there's what? Anemia. Isn't it? But it's because you want to what? Transfuse. They want to do your full blood count. So again, full blood count will tell you that the person is having what? Low HB. Low HB. And that will necessitate you to what? To transfuse the patient. And again, the full blood count can also tell you the platelet count. And some of these stuff, it can tell you. It can tell you. So you want to find out all of these things. And then, Charlie, you are just good to walk away with maximum point. All right. Outline 4 steps in the immediate management of this patient. In the immediate, again, they've told that what? It's what? Emergency room. So in the immediate management. So again, you want to assess hemodynamic status. Assess the hemodynamic, meaning that you are going to do C. So from your ABC, C means what? Circulation, isn't it? Circulation means that make sure that blood is flowing through everywhere. So by circulation, that's what we do. So the C is where you do your IV fluids. Some of you don't know. But the C is where you do your IV fluids. Very good. So you want to assess the C, which is what? Hemodynamic status. So how do you assess that? So you want to check if the person is dehydrated in a way, okay? If the person is anemic, like paper white, paleness, you want to check. So that is what? Assessing the hemodynamic what? Status. And if the bleeding profuse, very good. Then you want to give oxygen if it is required. You want to give oxygen if it is required. Then you want to give a local pressure dressing. When we say local pressure dressing, where they have done the circumcision, you want to apply gauze on it and tighten it very well, so that it will not bleed. Don't forget that if you do how do you call it? Pressure dressing, it always reduces what? The bleeding. Just like when you get a cut on your finger, you want to press on it so that the bleeding doesn't come out. The same way, that's called what? Pressure dressing. So over here, you want to do what? Pressure dressing for the child so that the person will not bleed too much and end up dying on you. So you want to do that. Then again, you want to make surgeons assess the patient if the bleeding requires ligation. The bleeding requires what? Ligation. Let a surgeon. Now I'm doing surgery. So cause people like us to come and assess if the person will require what? Ligation. But not if you come into, I'm going to call my boss. All right. Next thing, you want to do a transfusion. Very important. So you want to transfuse. Good. So talking about transfusion, they can ask you in Viva, what type of transfusion will you give? Because there are different types of transfusion. We have a whole blood transfusion and we have what? Plasma transfusion. So the question is, when do you give whole blood transfusion and when do you give a plasma transfusion? So that's assignment for you. And when we say whole blood, what does it mean whole blood? And when we say plasma, what does it mean plasma transfusion? So please, that's an assignment for you guys. I've not said it before. So it's an assignment for you guys to go and what? And check for me. Again, when do we give whole blood? When do we give plasma? And what at all is a whole blood transfusion? And what at all is a plasma transfusion? There are differences. So you need to know them as a doctor, because during night shift and patient comes bleeding, you must know what to give. You must know what to give. All right. And again, depending on clinical assessment, you would want to give vitamin K. You want to give IV vitamin K. IV vitamin K. Because vitamin K also helps in what? In coagulopathy. Sorry, in coagulation. Coagulopathy means the disease. So you want to give vitamin K to help in coagulation or clotting. To help in clotting. So these are the management. I think we have mentioned more than 4, but mention them. So you want to assess the hemodynamic status. You want to give oxygen if needed. You want to do a local pressure dressing. You want to allow a surgeon to assess if there will be ligation. And again, transfusion, whole or plasma. So you want to know which one will you give. Then depending on the clinical assessment, you want to give IV vitamin K. IV vitamin K. So these are your treatment management or your immediate management for this baby. Before you start going to what? Before you start doing the labs. All right. So ladies and gentlemen, thank you. And then this brings us to the end of today's presentation.